transition from the usual in-person mode to, or in-person meeting to a virtual conference. And congratulations to all the organizers. Congratulations, Sanjeev and your team. And again, thank you for inviting me here. My topic, ethical issues in interventional nephrology, certainly I try to bring in a new case scenario every year, and hopefully with the current trend in the big pipeline that we have on newer techniques that we use for AV fistula creation, newer techniques for creating AV access for our dialysis patients, more ethical issues do crop up every day. Let me make a disclosure here that I'm not an ethicist. I am a clinician like all of you attending and participating in this webinar. I face these challenges every day, and what I will share today is some of my thoughts and some of my experiences with the newer technology. When we talk of ethics, there are various definitions and various points where we often confuse things between ethics and morality, ethics and legal issues, and ethics and values. But in all practicality, what we really mean in clinical terms, in our clinical practice, is medical ethics is trying to do the right thing while achieving the best possible outcome for every patient. We certainly want the patient's interest and goals of care, and the principles and theories that direct us apply to just about every problem or situation, no matter whether it's interventional nephrology or general nephrology, patients you're seeing in the clinic, patients you're seeing in the ICU. But today's focus, what I will do is, first couple of slides, I will go over the basic principles of medical ethics and then provide one case scenario that I think is very relevant with the upcoming newer technologies. So 4 basic principles: autonomy, beneficence, non-malfeasance, and justice. And they all revolve around values that are addressed between a patient and a provider when they interact in any setting. And the common value that we all try to achieve are the fairness. We don't want to be unfair to one group versus other, minimize disparities as far as possible, be honest to our patients, and then respect whatever decisions they ultimately take based on the discussions that you've had. Autonomy, in short, it's the right to control. So informing the patient to choose or to refuse a treatment. And that decision can happen only when the discussion is open and fair. And even after that discussion, if the patient decides against a treatment, then as physicians, the more moral and ethical decision should be to respect that decision, even if it is harmful to a patient. And I can give you an example here that where I had a 55-year-old, a young patient who reached end-stage kidney disease, moving towards dialysis, opted against dialysis and just wanted a conservative medical care. And despite understanding, despite knowing a very well-educated person, he just didn't want to be on dialysis and get into the whirlpool of dialysis, transplant, rejections, back on dialysis, and he just opted a quality of life that would give was short. But again, we respected that decision and moved forward with helping him with his goals of care. In this modern complex medicine and modern era, getting an informed consent is very important, making sure that the consent is offered in the patient's own language that the patient can understand. If there is a language barrier, using a trained interpreter. And then these consents can become very complex when we are talking about advanced directives, care for minors, care for mentally ill patients, and scenarios that we see more and more often in our clinical practice. Beneficence means benefit to the patient. Non-malfeasance means do no harm. And essentially, it's striking a balance between good over harm. And when it comes to procedural practice, the three key questions that we often ask are, is the procedure really indicated? Should we really proceed with the procedure, or is it going to cause more risk and complications? Am I trained to perform this procedure? So as a person performing these procedures, training and developing skills is equally important. Until you develop those skills, I think it's relevant that you have a good training, a standardized training program that can get you to the point where you need to be. And finally, justice. It's again, complex healthcare issues, healthcare policies. Justice is more towards the overall healthcare policy that the government or the society implements, and allocation of resources, minimizing disparities, distribution of burden and benefit. So you don't necessarily have a pot of money allocated to one kind of disease versus the other kind of disease process is neglected. And how should this be divided? What kind of healthcare budget needs to be allocated? These are larger issues, larger societal issues where I think input not only from the community at large, the population that's affected, the professionals, as well as the policymakers, all of these should be part of this decision process. So finally, coming to my case for today, Mr. Shaker is a 38-year-old gentleman who's a newly diagnosed CKD5, is getting ready to start hemodialysis and agreeable to getting an AV fistula. He has well-preserved veins in his forearm and is an ideal candidate for a radiocephalic fistula surgery. However, he has heard of this new technique of minimally invasive endo-AVF or endovascular AVF, also called as percutaneous AVF. And I know we have some sessions that will go over this new technique. And it's relatively new. It's been in the market for around 3 years. He's heard about it, he's read something over the internet, and he insists that he wants to get an endo-AVF and not an open surgical procedure. Now, as a physician, you have recently acquired the skill and want to establish this new service at your hospital, and you're desperately looking for patients who would be agreeable to getting this AV fistula endovascularly rather than surgically. So this becomes a huge ethical challenge. How do you approach this ethical problem? Now, what we really know is from our clinical experience, from outcome studies, that guiding principle and standard of care when it comes to access creation is we start distally and move proximally. So we start as, if possible, snuff box. These days, the vessels in the snuff box are not often amenable to AV fistula surgery. So we often start at the radiocephalic fistula. If that's not an ideal site, we move on to creating a proximal forearm fistula, and then move on to the upper arm for either brachiocephalic or a transposed basilic vein fistula. So that's generally the guiding principle, the accepted standard of care when we talk to the patients about fistula surgery. Endo-AVF, those of you who are not familiar, is performed in the proximal forearm. So you skip the radiocephalic fistula site, and then you move towards the forearm, mid to proximal forearm, and these are deeper veins that are used to create an AV fistula. Long-term outcomes of this fistula that's created still remain unknown. I mean, this is just a 2-year technology that has been implemented widely in clinical practice. And there are no comparative studies between a surgically created AV fistula versus an endovascularly created AV fistula. So clearly there are issues. As a physician, you really want to practice your skill, newly developed skill, and from the patient perspective, it's more aesthetic. They feel it's less surgical trauma, and probably they would get a better access success rate. But clearly, we really don't have any evidence to show that one treatment is better than the other. And especially in this patient, he has a clear radiocephalic site, which we know that if a radiocephalic fistula can be created, those tend to stay open for a longer period of time, and eventually every fistula fails. So we really need to preserve these sites as far as possible, and start, as we have a standard of care, start distally and move proximally. Now I'll tell you what we do at Cleveland Clinic. Here we have a team approach. So each patient is evaluated by a team. The team includes a surgeon, a radiologist, and an interventional nephrologist. So all of these patients are evaluated. These patients, most of them have either started a dialysis with a catheter, or they are getting ready to start dialysis, so preemptively. So every patient gets evaluated, an ultrasound is performed, the vessels are evaluated to see if they are ideal for a surgical creation versus an endovascular creation. Details are discussed with the patient, and the patient is offered all the options and explained the pros and cons, like I just described, that there is very little evidence, and a great length of time is taken to go over these specific issues. Most patients, like Mr. Shaker, agree to a surgical AV fistula if that really is an option. So we've been doing this for the past 1 year, and just to give you an example, we have evaluated close to about 90 patients who have been screened, who have gone through this process of meeting the team. They've had their preoperative ultrasound evaluation, and only 2 of these patients ultimately were found to be appropriate for an endovascular AV fistula. So clearly this is something that is evolving. We all need to be cognizant of the fact that this is a new technique with very little evidence about superiority or better outcomes over the gold standard radiocephalic AV fistula. Agreed, if the patient really insists at the end of the discussion and at the end of all these exercise that he still would like to prefer an endovascular AV fistula, then in that case, a proper consent is documented, and the patient's will is respected, patient's decision is respected, and that's autonomy. And then one should move forward with an endovascular AV fistula creation. So yes, these kind of ethical issues do come up with everyday clinical scenarios, and I think this should set the ball rolling for today's event. I wish you all the very best of luck for this procedure, for this virtual conference today. Take home message, I would say, high quality healthcare requires providers to be responsible in protecting the welfare of our patients. Some of the ethical issues that we discussed today is preserving appropriate professional behavior. You don't just go badgering the patient and tell the patient to do what you feel is the right thing. Be truthful and trustworthy, treat all patients respectfully, and avoid conflict of interest that may compromise objectivity. Thank you very much again for this opportunity, and very good luck and best wishes for this meeting.